Hi, I'm Glen Gejerman. I'm a radiation oncologist. Primary practice is urologic malignancies. I work at New Jersey Urology at Summit Health, and I'm really very excited to speak to you about the Barrigel Spacer. All of us that practice urologic oncology have an appreciation for the fact that this is really an exciting time to practice. There have been a lot of innovations, and I think rectal spacing is an important tool that we can offer our patients to make radiation therapy a whole lot safer. And the question is, do we really need rectal spacing? Um, Over the past several decades, we've had a tremendous improvement in image-guided radiation techniques, which makes radiation a whole lot safer and has allowed us to dose escalate and achieve better biochemical outcomes. We probably hit the maximum ability to achieve further improvements in sparing rectum. I don't know that we're going to get better outcomes with more technology vis-a-vis CT planning, MRI planning. I think it's important for us to recognize that there is a limit for what we can accomplish in terms of separating the rectum away from the target volume. And why is that important? Well, if you see on the slide here, there are, fortunately, it's only a few patients, but a small percentage of patients that go through radiotherapy can end up with proctopathy, and depending on how you define that, it could be rectal bleeding, it could be pain, it could even be a mucoid discharge. I've spoken with colleagues who say, well, that's not really a problem in my practice. But the reality is, if you look at the data and if you talk to people that practice at large centers, you are going to see rectal toxicity. And so the ability to put in a rectal spacer really improves our patients' quality of life. And there's all sorts of prostate rectal spacers. There's the PEG, hyaluronic acid, collagen, there's a biodegradable balloon. And I have to say, I'm really agnostic into which type of rectal spacer one uses. I think it's important to use one. I do hope to convey the benefits of the Barrigel Spacer in tonight's talk, but just want really everyone to think about the importance of doing some kind of spacing. And so when we think about how do you optimize outcomes in spacing techniques, I've just listed a few, but we could probably double or triple this list. I find that it's extremely important to have a good bowel prep. And as I go around the country and scrub in on cases or talk to other physicians, there's quite a bit of variation in how meticulous people are in terms of the bowel prep. I find that extremely important because if you can't get a great ultrasound image, it's very difficult to get your needle where you want it, to get your spacing where you want it. Proper patient positioning, I'm going to show you a video. We tend, because we come from a brachytherapy background, we want to open up the pelvic inlet. We tend to put the legs way up, and I think it's really important if you want to flatten out the recto-pubic space. You really do want to have your legs in a more neutral position. I'll show you that. Meticulous ultrasound exam. I'm very fortunate. I'll show you the video. I've got a dual screen. I can look at axial and sagittal in real time. But if you don't have that, and I practice some places where you don't have the benefit of that ultrasound, just take your time, make sure that you've got a good image, both sagittal, and then if you have to flip over to axial, make sure that you can really see where you are, because that's the only way you're going to achieve ideal needle placement. You want to be comfortable with the anatomy, and if you have to brush up on ultrasound anatomy, by all means do so, because you really want to access the perirectal space. And when you do inject, you want to have a slow, controlled injection. If you force too much of the gel without reassessing, I think you lose the real benefit of Barrigel. I mean, the beauty of Barrigel, I'll show you on the video of the procedure, is that after you inject, you could step back and say, okay, where am I? Do I need to improve it? Am I symmetrical enough? Do I have gel between all the way from the apex to the base? And if not, you have an additional 2 syringes that you can fix that up. As you're going through the case, you want to look at ultrasound evaluation, and eventually you want to have a feedback loop by looking at your CT or MRI, if that's what you use, dosimetric evaluation to really evaluate, with this great technique that you're developing in the OR, are you achieving what you think you're achieving? And when you evaluate the spacer, we're specifically looking for symmetry. You don't want to put the gel all the way to the right or to the left of the prostate, and that can happen. It has to do with the patient's anatomy. Again, with Barrigel, you can fix that. Have your spacer extended from base to apex. With other products, you don't really have the ability to fix that, but with Barrigel, you do. And then you want to really maximize the space between your prostate and your rectum. Here's some examples. Ideally, on the left of the screen, you see a nice placement. Your Barrigel really goes from base to apex. It's symmetrical all the way right to left. And I think in picture A, you see that. But in picture B, it's a little bit more over to the right side. It's still a decent placement. I think you're going to get good dosimetry, but you can see it's pretty eccentric. And so I think that you're not going to get as much separation as you want in a patient like that. So let's dive in. Let's take a look at a case. The typical case should take approximately 5 minutes. The first thing you notice is, my assistants always put the legs way up. And first thing I do is I walk in, I lower the legs because I know that I'll have a much easier time placing my needle. And so here you see two views. You can see the axial, the sagittal, and you can see the real time I'm putting the needle in. And really what I'm looking for is I want to access the space right under the non-invasive fascia. Now, with this product, you are not going to hydrodissect, and we can talk about that, why that is. And I've had colleagues say to me, well, it's impossible to get access, if you don't have hydrodissection, and that's not true. You certainly can, but you need to spend a couple of minutes before you, during the case, position your legs properly, angle your probe properly. If you need to angle it downwards so that you open up the space, that will help. And then you really want to play with your views to make sure that you can see where you are. So you see in my sagittal view, I'm pretty happy with the placement. I'm below down vas fascia. I would imagine as I inject, I should be in the perirectal space. But I also want to then scroll back and look at my axial view. You see on top, as I'm moving my needle to the right and left, I want to make sure that I haven't caught any of the rectal capsule or the prostate capsule. I can move my needle around. Now you see it that I'm attaching the syringe, and I'm going to, once again, I double check to make sure that I'm in a good position. I know where my needle tip is. I stress this over and over, don't inject without your needle tip. So that's my first injection. That's my second one. And I'm pulling back because I want to make sure that I have good coverage all the way to the apex. And you can see even after pretty much my first syringe, we got pretty good space there. Now, a very important step is always reinsert the needle through the gel, because otherwise you can lose your space. You won't know exactly where you are. And then I scroll through the axial to make sure that I'm symmetrical, right to left. And if I'm not, I'm going to move my needle around to fix that. So I seem pretty happy with that. Again, I'm positioning now to make sure that I know exactly where my needle tip is. And after I'm satisfied that I'm happy where my needle is, I've again accessed the space. I'm pulling away from the base a bit because I have enough coverage there. I'm going to swap out the cartridge, and I'm going to do the next injection. And you can see it's quite simple. There's not a lot of preparation required. You don't need an assistant to help you with that. So again, now I'm about to inject, but before I inject, I again double check, where's my needle tip? Can I see it in my sagittal view? Okay, so I'm pulling back. I want to be more towards the mid gland. I do my first injection, open that up a little bit, pull back towards the apex, do my next injection, make sure I know where my needle tip is. And if I have to move my needle right to left, I'll do that. So I check on my axial views to make sure that I'm getting good symmetry. And if I have to move to right or left, I'll do that. And again, after each cartridge, I double check, okay, where am I? Am I symmetrical? Am I getting nice placement? Am I in the right space? I've heard cases where people can inject and end up in the rectum or it gets embolized. And that's simply because, I think the practitioner was not checking to see that he understood where his needle tip is. And so on this evaluation, I've got plenty of coverage at the base. I'm going to come back a bit. I want to go more towards mid gland and maybe open up a little bit at the apex. So I attach my cartridge. Again, always checking that I know where my needle tip is. I come back to our mid gland. You can see that additional injection open that up. But I want to make sure that I have adequate coverage at the base, and I inject there again. Okay, and then when I'm done, I'm going to scroll through to see what I've accomplished. Now, as we look at CT evaluation and dosimetry, I've heard that there's some practitioners have difficulty seeing exactly where the product is. And that should really not be a problem. As you can see here on the CT, you can clearly see your prostate, you can see your bladder very nicely. We put vesicoil markers in. You can see the seminal vesicles very nicely. And just on the seminal vesicle, you see on the slice, you can see if you have to play with your windowing, you do that, change your window level, and you can really see the Barrigel product very nicely. And so the complaint that I hear from some people is that it's difficult to evaluate on a CT. Some insist on doing an MRI. I think that that adds a lot to the expense. I think it's difficult for the patient to have to go through another procedure. So we got very comfortable with our dosimetry team, just playing with the window leveling and just being able to identify the Barrigel in a good spot. You can see it's very nicely in this case. It's got very symmetrical, going all the way from right to left. I've got pretty good separation between my prostate and the rectum, all the way from the base to the apex. I'm going to look at it on my sagittal view. And when I contour in, I'll show you after we contour in where the prostate, where the rectum is, you can see a pretty good separation. So we'll highlight those structures. We have the prostate, we'll show you the rectum, and you can see all that space in the middle was caused by the gel. As you can imagine, as you improve that spacing, you're going to get pretty nice dose volume histograms, which I'll show you. So I think that, the concern, here's your dose volume histograms, and you can see a pretty nice separation between your prostate and your rectum. So you see the rectal DVH falling off very nicely. So I think that the concern about not being able to see, I think, is overdone. I think it's something that you're going to have to get comfortable with. So we had the film crew with us filming 7 cases. I'm not going to show you all of them, but I also don't want you to think that I selected out the best cases. So I wanted to show you at least a representation, mainly mid-gland, of the 7 cases. And while you can see some variation, some are a bit more symmetrical than others, some open up the space a little bit better. A lot of that has to do with patient anatomy. Clearly someone with a prostate gland more than 60 gram, you're not going to be able to get that opening as much. But what you can see here, that with all the variabilities in the patients, we still achieved a fairly symmetrical spacer, and it really did open up the space. So I think that with meticulous planning, and especially if you allow yourself to get that feedback from what you do in the OR, sit with your dosimetrist, sit with your physicist, take a look at your scans to make sure that you're achieving what you intend to, you really can get great quality and reproducible technique. So the pivotal trial that was published in JAMA Oncology was a very important study. It was a moderately hyperfractionated study, giving 60 gray. And I'll say, I think it's important to use spacers, whether you're doing standard fractionation or hypofractionation. But obviously with hypofractionation, larger doses becomes much more important. And certainly if you're doing ultra hypofractionation. And the goal of the study was to see, could we achieve more than a 25% reduction in V54 to the rectum? And clearly you see that you can do that. 98.5% of the patients had more than a 25% reduction, which really is astounding because many of the practitioners who participated in the pivotal trial had a limited experience with spacing. Some had a lot, some used other products and switched over to Barrigel. And I wasn't surprised to see that they could achieve that, but there were some that really did not have a whole lot of experience, but with proper training, a lot of discussion about meticulous technique, they were able to achieve that. And so overall, there was an average 85% reduction of V54, which is fantastic, and 20% of patients achieved 100% reduction. The space is stable. It remained throughout the course of treatment. And then eventually, I would say, several months later, the implant will gradually resorb. I had a couple of patients that went on after standard fractionation to about 50 gray, went on to high dose rate brachytherapy. And so they had their procedure done about 3 months after we placed the gel, and it was still stable. So it really does help long term. And of course, 0 Barrigel related adverse effects. I think that has to do with knowing where your needle tip is, making sure that you're not injecting into the rectum or not into any blood vessels or lymphatic vessels. That's really key to the technique. The study looked at whether one could reduce GI toxicity. And if you look at the GI toxicity, those that had spacers had very limited grade 2, grade 3 toxicity. So more of that if you just did control. But if you look at, grade 1 versus grade 0, clearly a big benefit to using the spacer. And I have to say, I have a very high volume practice, and a lot of my practice in the past had been managing mucoid discharge and a little bit of a pain and rarely, but sometimes rectal bleeding. By and large, that's gone away. So this really can transform your practice. And most importantly, it'll transform how your patients tolerate radiotherapy. So the conclusion is that as we want to improve our patients' lives, we want to continue dose escalation, we want to continue to find what is the proper dose for hypofractionation. It's really important to think about rectal spacing. And I think that Barrigel has many benefits. The fact that you can inject and then evaluate in the OR and take your time. You inject one cartridge. Am I happy? Am I symmetrical? Well, if not, I can reposition the needle and achieve symmetry. Did I get enough of the product between my base to apex? And a lot of the other products have that as a drawback. You talk to practitioners that use some of the other products, then they may get a lot of product, a lot of gel near the base, maybe mid-gland, but not so much near the apex. But you can see that and correct it with Barrigel. So I think it's extremely valuable product. Feel free to reach out to the company. Very supportive. You can reach out to your rep that comes with you or submit questions to the company. If I can be of any help, feel free to reach out to me anytime. Thank you very much.